Thanks a lot to the organizers, Vivek, Chandrakanth, Dr. Parik, and all the organizers of ICON. So in the next 15 minutes or so, actually Amish had given me
Recording in progress.
A very spicy topic to speak on, which was that, geriatric assessment should not be done because it doesn't impact on survival. And I think this is what we are always question, why do this whole complicated, comprehensive geriatric assessment if it doesn't really have any impact on clinically relevant outcomes? So I'll just try to touch on these points. So what are clinicians' viewpoints on the impact? What are patients' viewpoints on what is important? Do we have any proven benefits in the literature for the geriatric assessments in terms of communication, prediction of toxicity, treatment decision making, reduction in toxicity, and quality of life? And then if we have time, I'll briefly touch on our experience at the Tata Memorial. So what are clinicians' viewpoints? We had done this exercise, based upon a similar discussion a couple of years back in one of the conferences, that geriatric assessment does not impact on survival. So we asked, is this really the most important endpoint in older patients with cancer? Is prolongation of survival the be-all and end-all? So we had surveyed 222 people, oncologists, so medical radiation surgical oncologists in India and globally. And it was heartening to see that 99.5% of them thought that either a decrease in toxicity or an improvement in quality of life were at least as important as prolongation of survival. 63% thought it was more important and 37% thought as important. And what do patients think? So it looks like patients seem to be have similar viewpoints. In the palliative setting, 65% of our patients, so these are patients we saw in our geriatric oncology clinic, if they were being treated in the palliative setting, so 65% of them said their goal was improvement in quality of life. Approximately 25% wanted immediate symptom relief. So about 80% of patients wanted quality of life symptom improvement in the palliative setting. In the curative setting, surprisingly, about 30% of patients actually prioritized an improvement in quality of life or symptom relief, even in the curative setting. So in our patients in the palliative setting, 9 out of 10 value quality of life or symptom relief. And in the curative setting, a third of the patients value improved quality of life and symptom relief. So coming to the actual benefits of the geriatric assessment, I'll skip what the geriatric assessment entails for lack of time. But we know there are multiple well-conducted trials regarding what are the actual benefits. So the first would be communication. So this was the COACH study conducted by Supriya Mohile and colleagues, and was published in JAMA Oncology a couple of years ago. And in this study, they randomized patients to undergo a geriatric assessment, and the results of that geriatric assessment were just conveyed to the treating physician. That resulted in improved patient satisfaction with communication. So this line on the top indicates the geriatric assessment cohort of patients. The bottom line indicates the patients who received standard care. It also, the geriatric assessment patients also had improved patient satisfaction with overall care. And not just the patients, the caregivers were also more satisfied with communication. The patients who underwent the geriatric assessment also, in them, there was also an improvement in all age-related concern conversations, higher quality age-related conversations, and more conversations regarding the geriatric assessment-driven intervention and recommendations. So from the COACH study, we found that integrating the geriatric assessment into a community oncology practice. So this, I forgot to mention that this was conducted in community oncology practices, not in academic centers. This improves patient as well as caregiver satisfaction and communication about aging-related concerns. Now, I can see that probably Amish will say, communication is all fine, but does it impact on what we consider clinically relevant? So toxicity and quality of life are widely considered to be clinically relevant endpoints. Does a geriatric assessment predict toxicity? And we are all well aware of this CARG, chemotherapy toxicity risk score. This was published by R.P. Huria over a decade ago in JCO. And these are the factors that are a part of the CARG score. So the CARG score can vary from 0 to 19. So 0 to 5 indicates a low score, and that score is predicting the risk of grade 3 and higher chemotherapy-related toxicities. A CARG score from 6 to 10 is considered intermediate or medium risk, and a high CARG score is 10 and over. So patients who have a low CARG score versus medium versus high, there is a very nice prediction for the risk of chemotherapy-related toxicity. Whereas the physician-rated performance status does not at all correlate with the risk, with the occurrence of grade 3 and higher toxicities. So in patients who had a low carb score, there was a 30% risk of grade 3 and higher toxicity. With a medium carb score, it was 52% risk of grade 3 and higher toxicity. And if their carb score was high, so 10 and higher, there was an 83% risk of grade 3 and higher toxicity. And that was a statistically significant difference. And you can see, based on the physician-related ECOG performance status, really there was no real prediction of the grade 3 and higher toxicities. So does the geriatric assessment impact on treatment decisions? Now, we've had multiple studies to tell us that yes, it does. This was one of the more recent studies by Sudet et al. Published in BMC Cancer in 2020. In 384 patients, they found that the geriatric assessment led to a change in plan in about 17% of the patients. And the changes recommended included a decrease in the intensity of chemotherapy, change in supportive care, less aggressive therapy, change to hormonal therapy, etc. So there was a systematic review published by Hemaker et al. This was the first systematic review. It was published in Acta Oncologica in 2014. And they found that the initial oncologic treatment plan was modified based on the results of the geriatric assessment in a third of the patients. So a median of 32% of patients, and non-oncologic interventions. So for example, nutritional support, cognitive intervention, things like that, were recommended in a median of 83% of the patients. Hemaker and colleagues updated their systematic review, which was just published a month ago in the Journal of Geriatric Oncology. And the solid blue bars indicate studies that showed a benefit, and the dotted bars indicate no effect, and this black bar indicates negative effect. So you can see that the geriatric assessment led to a positive impact on toxicity and complications, treatment completion, and physical functioning and mobility. There is unclear evidence about the effect on the quality of life in terms of the systematic review. So the systematic review included 65 publications from 61 studies. The oncologic treatment plan was altered in a median of 31% of the studies. The highest change rate occurred in studies where there was access to a multidisciplinary team evaluation, and non-oncologic interventions were recommended in over 70% of the patients. The geriatric assessment led to more goals of care discussion and improved communication, lower toxicities, more treatment completion, and improved physical functioning and quality of life. So we can predict toxicity, improve communication, change treatment, but does it reduce toxicity? So we had, I'll just go over 3 landmark studies that were just published in the last couple of years. One was the GAIN study published by Danning Lee and colleagues in JAMA Oncology last year. So in this study, they randomized patients to undergo a geriatric assessment, and then they intervened. So there were geriatric assessment guided interventions or standard of care. And you can see that the geriatric assessment intervention arm had grade 3 and higher toxicities. There were all grade 3 and higher toxicities in 51% of patients, whereas in the standard of care arm in 61% of the patients. So there was an absolute reduction in grade 3 and higher toxicities in 10% of patients, which was a statistically significant difference. So implementation of geriatric assessment related interventions significantly reduced grade 3 or higher chemotherapy related toxic effects. The other very similar study was the GAP 70 plus study. This was led by Supriya Mohile and colleagues, and it was published in Lancet Oncology last year. So in patients who underwent standard treatment without a geriatric assessment, there was 71% of those patients had any toxicity, whereas patients who underwent a geriatric assessment, and that geriatric assessment was communicated to the treating physician, only 50% of those patients had grade 3 and higher toxicities. So here an even higher change, so 21% absolute reduction in any grade toxicity. Did that? So most of that reduction in toxicity was because of a de-escalation of therapy. So decreased dose, there was a dose reduction, but did that impact on survival? It did not. So a geriatric assessment summary with management recommendations provided to the oncologist prior to the start of a new treatment regimen reduced the clinician-rated grade 3 and higher toxicities over 3 months without significantly lowering survival at 6 months. The third study was the Esogea study that was published several years ago. And in that, briefly, patients were randomized to decisions of patients who were 70 years and older with advanced non-small cell lung cancer. They were randomized to a treatment decision based on routine performance status and age, or to the geriatric assessment directed therapy. So based on the geriatric assessment, they were determined to be fit. And if they were fit, they received combination platinum-based chemotherapy based on the histology. If they were vulnerable, they received single agent dosing, and if they were considered frail, they received best supportive care. So now this, in the geriatric assessment arm, there was no decrease in the treatment failure-free survival. However, there was again a significant reduction in toxicities. So this geriatric assessment guided treatment allocation, although failed to improve the time to treatment failure overall survival, it did decrease toxicity. And the last point is, does it improve quality of life and this concept of overall treatment utility? So I just like to highlight the GO-TO study. This was a landmark study published by Peter Hall and colleagues last year in JAMA Oncology. And in this study, they took patients with advanced gastroesophageal junction cancer who were in the geriatric age group and not fit. So they were frail patients, not fit for full dose 3-drug chemotherapy, but suitable for reduced intensity chemotherapy. So 500 patients, the clinicians thought that they certainly should receive some sort of chemotherapy, and they were randomized to level A, so that's 100% of Kpox, level B, which was 80% of Kpox, and level C, which was 60% of Kpox. If the treating physician was uncertain whether chemotherapy should be used, so these were the frailer patients, they were randomized either to the level C, so 60% of Kpox, or to best supportive care. The primary endpoint was a 3-year progression-free survival. Through this study, they also introduced this concept of overall treatment utility, which asked 2 questions. One was whether the clinician considered the treatment to be effective. So that was based on radiologic progression, clinical progression, or deterioration in the patient's quality of life. The second question was whether the patient found the treatment tolerable, and that was based on toxicity, the interference of treatment with daily life, and whether the patient felt treatment was worth it. And that could be good, so both clinician and patient said it was good. Poor, so both said it was bad or the patient died, or intermediate, either one thought it was good. So they found that patients who were randomized to level A, level B, level C, the progression-free survival was non-inferior. The overall survival was also non-inferior. So 60% Kpox also led to a similar median overall survival as 100% Kpox. However, toxicities were significantly lower for the level C, so the 60% of Kpox, and overall treatment utility scores at 9 weeks were again best for level C. Quality of life were better for the patients. So the green was the level C, so the 60%, and the blue is for level B, so the 80% of Kpox.
Ma'am, can we request you to conclude?
Yeah, I will. So reducing the intensity of chemotherapy provided an improved patient experience with no significant detriment in cancer control. So I'll skip all of our TMH experience, and I'll just go with the last thing. So in our experience at Tata Memorial, did the geriatric assessment correlate with survival? And we included 909 patients from June 2018 to Jan of this year. Median age was 69. The geriatric assessment consisted of assessment of function, falls, nutrition, comorbidities, cognition, psychology, medications, fatigue, and social support. And an impaired geriatric assessment patient was found to be vulnerable in 2 or more of these domains. So, and we found that patients with a normal geriatric assessment had a significantly better overall survival as compared to those with an impaired geriatric assessment. And that was statistically, there was a huge difference. So I'll conclude that the geriatric assessment has several clear clinically relevant benefits. It improves communication, can predict toxicity, impacts treatment decisions, reduces toxicity, improves quality of life, and improves overall treatment utility. So it is time for us to stop saying that the geriatric assessment is too time consuming. I'd like to acknowledge the entire multidisciplinary team of our geriatric oncology clinic at the Tata Memorial. Thank you very much for your attention.
Thank you, ma'am. I'll now call upon our moderator, Dr. Amish Vora, medical oncologist from New Delhi, and his panelists are Dr. Manish Kumar, medical oncologist, New Delhi, Dr. Rajiv Vijay Kumar, medical oncologist, Bangalore, Dr. Kalyan Kusum Mukherjee, medical oncologist from Kolkata, Dr. Reshma Puranik, medical oncologist from Pune, and virtually we have Dr. N.N. Prem, geriatrician from Mumbai, and I request the session director to also be part of the panel. Over to you, sir.
Thank you. Can we, so Vanita, can you hear us? And Dr. Prem, are you there?
I'm here.
Okay, you are there.
I can hear you.
And Vanita also you can hear. Vanita, thank you so much. It was a wonderful presentation as always. Stay back. I have, so we will straight away start with questions. I think, so we have Dr. Rajiv here, Dr. Reshma, Dr. Kalyan Kusum, okay, and Dr. Manish Kumar. Fine. Okay, we have that. will try to finish. So I told Vanita also, and I always ask myself the most important question, is CGA helpful? We will not go into that detail. What ESCO has recommended from 2018 and what we have been practicing is minimum recommendation which is required for CGA to begin with, and these are the detailed 8 aspects. If we do that diligently, it takes around 20 to 25 minutes. I love doing it because I have lot of time. So if anybody has been very busy and want to send, I can do that. Once we have some abnormalities, we go into the details of that. And in addition, we have G8, VES13, MMSC, Charlson Comorbidity Index. These are not been listed in ASCO minimum recommendation, and we can do any of these depending on the preference. So let us go to our first case. 84-year-old female, stage 4 ovarian cancer with pleural effusion, requires tap twice a week from pleural cavity, ascitic tap once every 3 to 4 days, came to us and I did CGA. CGA, according to the scales, I would not go into the details. What was the impression? That the patient was not fit for chemotherapy combination. Paclitaxel, what we standard give to these ovarian cancer patients, stage 4 disease. Single agent chemo, according to CARG calculator, she had 74% chance of having grade 3 to 5 side effects. So very thin and frail lady, no muscle mass. PFT was restrictive lung pattern. GFR by DTPA is 43 ml per minute. Echo 50%, diastolic dysfunction. Hearing aid required, memory loss, query early Alzheimer's. And according to e-prognosis and Charlson CCI, is a 25% chance of her living beyond 5 years due to age. So what do we do? Let us start with Dr. Kalyan. What would you do in this patient?
Single agent chemotherapy is also grade 3, grade 4 toxicity.
Correct.
We cannot give the injectable for grade 3 and frail, all this thing. I think the best supportive care will be a good option.
Best supportive care would be an option. Manish?
You know, sir, to begin with, I certainly go by the assessment. But you know, at times there are certain diseases that we deal with. They are highly chemo-responsive. So I do feel tempted to start this kind of patient at least in a single agent platinum. So
okay.
I definitely, you know, would say oscillate between either best supportive care or single agent platinum.
Or single agent right now. Okay. Dr. Reshma?
Sir, considering the entire assessment which has been done and the prediction of risk of toxicities, looks very difficult that she is going to tolerate. So would want to avoid chemotherapy in
Would
her
want
case.
to avoid chemotherapy. Rajiv?
Sir, her problems lie due to 2 reasons. One is due to her age and one is due to the pleural effusion and the ascites. So both of them will be causing some amount of compromise. So therefore what I would like to do is put in a chest tube or put in a pigtail catheter, reduce her morbidity, see how much whether her activities of daily living are improving, and if it is improving, I would probably be more encouraged to give her some form of small chemotherapy, probably paclitaxel like around 50 milligrams per meter squared,
50
carboplatin 100.
milligram per meter square
So
and carboplatin 100.
Carboplatin 100 flat. Actually, it works in patients. This is not just theoretical, it's practically it works.
Okay. So, Vanita, since you are there, you heard the house is split. Vanita, what would you do in this patient? And the important question is that if the CGA shows that patient will not, patient is not fit for any combination or any chemotherapy, still if we go ahead and give chemotherapy, are we wrong in that? Vanita, what would you do? First question.
No, I think I'll take the last question first. No, of course we are not wrong. This is not a mathematical equation that, it says it is 75% and therefore it will be 75%. It is just, and, a lot of geriatric oncologists don't even give you the number of the CGA, because this we tend to assume that this is what it is. Just say a patient is at a higher risk, and then you decide. I think from your case, I got the oncology information. I got what the clinician thought, but one very important point is this has to be shared decision making. What does the patient want? Is the patient keen for treatment, and what is causing the most problem to the patient? Is it the symptoms of the disease? And if that's the case, or is it general debility and all of this frailty? So I think that would help you to decide what to do. And I
So
agree with the
patient
panelists to set a small
requires,
type of treatment.
so Vanita, patient has to visit hospital 3 times a day, 3 times a week, either for pleural tap or ascitic tap. Almost 2.5 to 3 liters in a 35-year-old, 35 kg lady. She was 35 kg weight. Very petite and thin all her life. She, from her bed to bathroom, she couldn't go without any support. So she herself and the family wanted that some improvement in quality of life should be there.
Right. So I think that is key. So how can we improve the quality of life? If you can get that done without giving systemic therapy, because systemic therapy would require her to come to the hospital, at least IV platinum or paclitaxel, and would give toxicity. So if you had some agent that was oral that could give her a little bit of improvement of quality of life, great. If not, do other measures, drain it and see if you can improve her quality of life.
Right. Dr. Prem, I'll come to you, but before that, I counseled the family and I told them that I also want her quality of life to improve. So I said, let us do CGA before and after pleural tap and ascitic tap. I thought, that might improve little bit. It didn't change anything. I was very skeptical of giving any intravenous chemotherapy, started her on oral tamoxifen, and I said that we will start oral cyclophosphamide little later if she tolerates. 1 month over, there was absolutely no response. Patient was fed up of poking needles. They refused for chest tube or pigtail. So after 1 month, I did CG again, and again it was exactly the same. So finally, what Dr. Manish said, we did that. I told them, I said she may die because of side effects of carboplatin. She may she may have infusion reaction. We started, carboplatin started with 60 mg, then 100 mg, then 120 mg. She tolerated everything well, and her ascitic tap frequency started reducing. Okay. We became little brave and we added nab-paclitaxel. 3 more weeks, further better. There was no toxicity of nab-paclitaxel. I reached up to 130 mg per week and 150 mg of carboplatin, and 150 mg of carboplatin with her creatinine was AUC 2 to 2.5. There was no neutropenia, there was no diarrhea, nothing. She was absolutely, she went on to finish 18 weeks of chemotherapy, double dose, nab-pacli and carboplatin, CA 125 from 6,000 became 23, no ascites, PET CT, very good partial response. It's almost 4 months now, she's on tamoxifen, her CA 125 remains normal. Dr. Prem, now you come into the picture. Dr. Prem, CGA was like, I am a very brave man, Dr. Prem, and I do a lot of this thing. I was so reluctant to start chemotherapy, and here we have a lady who has completed 6 cycles of combination chemotherapy without even grade 3 side effect, grade 1 maximum. And every time she's a Tamilian lady settled in Delhi with children, and she would say, "Baar baar kya puchta hai? Kuch nahi hota na mere ko." Very sweet, she used to say that. Where did we go wrong? Dr. Prem.
Most importantly, I think it's not, geriatrics is not about CGA. Let me be very, very frank. It's about making sure that from the assessment, what we are able to actually do for the patient. And I think the key is quality of life. So in this case, yes, maybe the CGA was showing us that the toxicity might increase, but the primary issue in her, in which the quality of life was really affected, was because she had severe ascites and the disease process was causing it. So we always knew that even if we drain the fluid, it might not actually help her out. So I would say, and another two things, of course, I would still, as a geriatrician, still want to even improve her hearing problems as well. And also maybe look at her Alzheimer's or whatever memory loss. It's not necessarily it will be Alzheimer's, and hearing impairment might be just earwax. So which might even improve her quality of life. But primarily, yes, her quality of life was hampered due to this. And more than anything, I think I've seen in older people, they don't always stick to the norm. They have shown a lot of resilience. Even in COVID, we saw younger patients die more easily actually as compared to a lot of older patients with multiple comorbidities. So I would say, yeah, I mean, your gut feeling was absolutely saying you shouldn't go ahead. But maybe in a way, the repeated CGA showing that it will actually, you won't want to go ahead, made you even say that, no, let me at least do that. And I think, in a way, a shared decision, which I totally agree with Vanita ma'am, it's not that CGA says don't do, it says there's a higher risk, but ultimately we should make sure that we don't just call it a norm in the sense that whatever CGA says, that is what we'll do. It is only to help you take a better clinical decision. I would say if I see the patient, I'll be like, go, maybe it's a high risk chemotherapy. You should try to go for it if it improves the quality of life. But at the same time, you would have obviously told the patient's relatives all the pros and cons of the same, and also try to take care of the other things which would be sort of quality. And I totally agree that the patient's perspective and what the patient wants should be taken into consideration. Maybe, I mean, if her mental status is still okay, then there should not be any paternalistic decision even from us or from even their caregivers.
Thank you, Dr.
Sir,
Prem.
can I add?
Yeah, please.
Just two small quick things, sir. So for this patient in particular, there was no way best supportive care could have improved her quality of life. So you feel tempted to take some action, and that's where chemo pitches in. And second thing, sir, something similar, about a month back, I received a similar patient, but different, but there was a 70-year-old lady, PS3, and she had a small NEC of stomach going towards small cell. I was a third doctor. She had visited 2 doctors earlier, big hospitals in Delhi. They refused, rightly so, and best supportive care. And they were hell-bent that I should do something, just that. And I being a big platinum fan, so I thought of starting something modified etoposide cisplatin. So first cycle I just gave her cisplatin 2 days each. It's been 4.5 weeks. She's doing well, and now I'm thinking of adding etoposide. So it works at times.
Absolutely right. So my takeaway in this patient is, as Dr. Prem said, geriatrics is not about CGA alone. That is one. We need to keep on improving ourselves to know. This 84-year-old thin petted lady who had multiple comorbidities, there is a 0% chance that she is going to survive beyond 7 years. And she tolerated full prescribed dose of paclitaxel and carboplatin at 84. Okay, second
Amish,
case.
sorry, can I just quickly interject?
Yes, Vanita.
I just wanted to respond to the point that the panelist had made about best supportive care not improving our quality of life. I agree somewhat with that. There are multiple things you can do with best supportive care to improve quality of life, but the important caveat to that is that you don't always have to be pushed to do something. And this was a wonderful thing, and you did. I mean, I'm amazed at your bravery, as well as this is why you are such an experienced geriatric oncologist, Amish. But the caveat is that giving chemotherapy may detract from her quality of life, so we have to be cautious.
Correct. No, point very well taken, Vanita. I am going to present a case where I have burnt my fingers in spite of you calling me a very good geriatric oncologist. Next case I present that.
Just a note that I have been treating a number of these patients who have really bad performance status, 80 plus. The point to note here is that the disease is very chemosensitive. So almost like the second case you are coming to, I just saw. So when you have a disease which is chemosensitive, try to get in some chemo which is going to improve their quality of life. That is the target. And I found that paclitaxel, single-agent paclitaxel given on a weekly basis is the least harming to the patient in this patient. And once they come up, then you can add your carboplatin and other things.
Dr. Singhvi, the important point what we are trying to bring here, that the way we define performance status, can we have something defined parameter in geriatric age group? What you are doing and what I am doing and what Manish suggested is out of our experience.
Yes.
It is more of the eminence-based medicine rather than the evidence-based. That is what we are trying to find. And I would like your comment.
For this reason, one thing to develop for India also, this like CGA. that CGA is not applicable in all the patients. What my
So Dr.
experience
Parekh and
is
our
not
group,
correct.
yeah, Dr. Parekh and the group is coming out with India-specific CGA, and we would request you to participate in that, and sir would say about that.
And it is important that here you should take into account the sensitivity of the disease to the proposed treatment. If it was a lung cancer, I'd probably not have done it. But you have a sensitive tumor.
So, Dr. Singhvi, I have 2-3 more interesting such cases. We'll go forward. Sir, quickly.
So just to add to what you said, Dr. Joeta, who is a professor and head of Geriatric Oncology at AIIMS, New Delhi, she has published a paper where she has actually devised a geriatric oncology assessment pro forma specifically for India. The 100 patients have been used to validate, and now we are going to do a multi-center investigator-initiated study. Our target is to have 1,000 patients
Correct.
to validate.
Done, sir. So the next case I would require you also, but let me go through the case. 93-year-old female, hypertensive, DM type 2, controlled, no arthritis, no CAD, euthyroid. I would keep repeating 93 years. Please remember that number. History of muscle non-invasive bladder cancer treated 11 years ago. In history, when we say 11 years ago, we feel long time back. But in this patient, when she was 82, she had bladder cancer. She came to my OPD walking without any support with the driver. She was diagnosed with CLL rise stage 3, constitutional symptoms, fever, weakness, and TLC doubling time of 3 to 4 months. Her TLC was 1,65,000 when she came to me. Okay, and she had constitutional symptoms. Her very specific point was she used to play cards every day for 4 hours, and she used to run a 3-star hotel in Kashmir herself. So 15 days at the age of 93 she would be in Kashmir, 15 days she would be in Delhi. I asked her, how do you travel? She said, in economy, airfare, I don't take any wheelchair while going, just to add on to how fit she was. I did every instrument possible for myself, which I knew for this patient, comprehensive geriatric assessment. Everything was normal. Everything was normal. Every examination was normal. I sent her to neurologist. I sent her to cardiologist. Everything was normal. I have not seen a fitter 93-year-old in my practice. What would you do? This was February 2021, not 2020, 2021. It was a peak of COVID. What would you do? We can start from Rajiv.
Sir, I would start her on ibrutinib, probably modified dose. I would not give her the full dose, probably.
Ibrutinib.
Yes,
okay,
sir.
Okay. And you would not be worried about the infection. Why not acalabrutinib, which is safer than ibrutinib?
Fine, sir. Since acalabrutinib or ibrutinib, one of them.
She can afford anything under the sun.
Fair enough. So, what therapy options do we have? We have one ibrutinib and acalabrutinib have become the now standard of choice. If not for that, the next thing is that we'll be doing just single agent rituximab. Now with COVID reeling, so you're a bit worried about her immunity. So therefore, we keep rituximab as in the back burner. The simple choice would be ibrutinib or acalabrutinib.
Okay, perfect. Dr. Purani?
Sir, I agree with ibrutinib. I have also used it because most of our CLL patients are elderly. So we have had a lot of experience using this molecule. If the patient is not having, not on blood thinners, like she was not really very comorbid, not having hypertension and other issues. So trying out a ibrutinib option would be very good, because otherwise rituximab would again involve admitting her and giving her. So ibrutinib would have been a good choice. No.
Right.
So it's a very leading question. You have given this question, that means certainly the patient had some problem going ahead. But still, given the scenario, I would like to start with either acalabrutinib or ibrutinib, whatever way is feasible.
Same.
This is the BTK inhibitor. Any BTK inhibitor in the compromised dose will start, and if she tolerates it, then we give the final.
So ibrutinib and rituximab, both I had discussed with her, and we'll come to that. So this was the few papers which I found, and there are many papers. Acalabrutinib or ibrutinib, the clinical trial, the highest was at 91 years of age. And she's 93. I discuss all these things with patient because in a private practice you have to be very careful. So what I told her, the consensus in patients above 80 years, the data is rituximab plus chlorambucil, which is one of the safe, and the median overall survival is 48 months, so that is around 4 years. And then I told her during COVID time, rituximab is the worst COVID enemy because there is a lot of reactivation. So she refused. She read the side effects of ibrutinib and acalabrutinib. She refused for that also. So my choice was to either give chlorambucil alone or cyclophosphamide alone. And I'll go through this case. I told her 30 milligram flat dose of cyclophosphamide with prednisolone 60 milligram for 3 days. This is what we decided because she refused for ibrutinib, looking at the side effects and opportunistic infections. Patient started feeling better immediately. I think that's a steroid effect. After 5 days, all chirpy, full of energy. 7th day, routine CBC, platelet was 30,000, hemoglobin was 6.4. TLC crashed from 1.5 lakh to 20,000. There were no signs of tumor lysis syndrome. She had urosepsis after 3 days. CBC repeat, TLC further crashed down to 4,000. Admitted for IV injections. Every day her TLC went down. It has touched the nadir of 400. She had hypotension. She was in shock, fever, oliguria. Luckily for me, I think so, after 17 days of hospitalization, she recovered. The question, I still can't, 300 milligram, and sir, Parik sir, 300 milligram of cyclophosphamide in a 93-year-old fit lady, leading to 15 days of pancytopenia. In a fit patient, absolutely, every instrument under the earth, every test under the earth was normal. Is it something unusual? Should I have done? I remember you teaching me cyclophosphamide was my first lesson in Tata Hospital, 7th floor.
So when the person is 91 years old, organ reserve is compromised. All of us know that with age attempt. And the current biological, biochemistry parameters that we use in blood tests will never tell you about organ reserve.
Correct.
So this should not be surprising, though it is not very common.
Right. So I found the FDA pack insert of cyclophosphamide, and they have just mentioned that go slow in elderly patients. Dr. Prem, what happened in this patient? We give 1 gram of cyclophosphamide like water, and I had started with just 300 milligrams because it was a peak of COVID time. I didn't want anybody to be admitted in ICU. What happened in this patient?
Of course, according to the geriatric assessment, one might say that, she was fit in every possible way. But my question to you would be, if we would not have given the treatment, then what was the survival we expect?
No, so rise stage 3 with tumor doubling time of 3 months, normally less than 6 months is specific. She refused for bone marrow, we sent the peripheral blood for FISH, which didn't reveal anything, so I don't know what was her cytogenetics. She flatly refused. 1.7 to 1.9 years, normally around 50% of patients, that would be the median survival.
Yeah, and what is the current status of the patient?
I'm coming to that. So since you asked that question, yeah. I'll complete the story.
Amish, can I
Vanita.
ask something? Sorry. So the only thing that I may have done differently, I think, in the assessment was because of a very advanced age and the fact that you were giving her a drug that is somewhat renally excreted. I think a quarter maybe of cyclophosphamide, little bit is renally excreted. In these older patients, we do the assessment of their renal function is not very good because their serum creatinine level is inappropriately normal because they have less muscle mass and they have less renal function.
Yeah. No, we did DTPA for renal scan.
You did a DTPA scan.
She was one of the most influential family of Delhi. So Vanita, I did everything possible before giving her. She kept on refusing. She would read pack insert of ibrutinib. She said, I don't want to take this. I told her acalabrutinib bolta naya drug aaya, I don't want to take this. Obinutuzumab, I don't want to take that. So finally I said, ये cyclophosphamide 300 mg आप tolerate कर सकते हो. And she didn't tolerate. So Dr. Prem, we stopped that. Little COVID was over. I gave her 4 doses of rituximab 3 weekly. She did well. Her TLC went under control. She was in clinical hematological remission, but she kept on getting urosepsis every month. She went into hypogammaglobulinemia. In spite of our best effort, 9th episode of urosepsis, we lost her. So we lost her faster than your question, she would have lived without treatment.
Okay.
I sat down with so this was a failure. This was a failure on our part, at least on my part, how I treated, what I looked. So sometimes when you look back, I sit with her daughter and I say, shayad nahi treat kiya hota to, would have been better. But that is a hindsight. But I am telling you, Dr. Prem, I have not seen a fitter 93, a fitter 83 than her. But
yeah, I would still
wrong.
say, I think a 93-year-old with every parameter okay. I mean, one is of course totally the organ reserve thing that Sir said. It is going to be, all the organs will be older. So what we know as of now is physiological reserve will be much lesser than when you actually give treatment and that side effect profile comes in, firstly. And secondly, I feel that the fact that she was diabetic, when there was obviously that unfortunate side effect of pancytopenia, the fact that she would get recurrent infections was just over the roof, with obviously a steroid also being taken. So a stable diabetes before, but when maybe treatment was induced, it was sort of, so I would still say that I don't think you were absolutely wrong in going for the treatment, because you went very much with you didn't go with your gut feeling here. You did a detailed assessment, you discussed a lot, and then you tried to give the treatment. So I think maybe you can just take it as one of those punches on our face which we have during practice, where we do everything, but then unfortunately we do lose the patient.
True. No, you are right. See, point is, I'm not shying away from presenting this, because this is one patient which taught us that 93 is just a number, but it does play sometimes the role. One, we have to be little careful. There is no way I would have predicted that 300 milligram of cyclophosphamide would cause 15 days of neutropenia, but it did happen. So, again, some learnings from this patient. Will go to the third case. 87-year-old female. This is the third female I'm presenting, but we have one male also. All are above 80, so I thought extremes of age would have been better to discuss today. 87-year-old female. Head and neck cancer, soft palate, large palate, hard palate, some lymph node in the neck, localized disease with unilateral cervical lymph nodes, family refused for chemo plus RT or surgery. Biopsy showed squamous cell with PD-L1 of 60%. Somewhere outside single agent pembrolizumab was given. After 2 doses, grade 3 transaminitis, responded to steroids. Again repeat dose was given. This time not only transaminitis but hyperbilirubinemia also was there. So the treating doctor refused to give further IO, and then they came to us. We did a CGA. So all the parameters, what I've just pointed this out to tell that I actually do CGA, and that's why I put my prescription here. She was borderline. Okay, this patient was borderline for chemotherapy. Single agent chemotherapy, doublet, again 80% and above, grade 3 to 5 according to CARG score. So let's start with Dr. Reshma. What would you do in this patient?
Sir, in her, because for her to even tolerate immunotherapy was difficult, and
Right.
borderline patient. So why not consider oral metronomic therapy?
Oral metronomic. Dr. Vijay Patil, Dr. Vanita and Kumar has given the world a new paradigm, and I'm very, very proud of them that this has given us some armamentarium in our private practice. Sir, what would you do, Dr. Kalyan?
So low dose nivolumab we can try.
Low dose nivolumab we can try. Manish?
Sir, with this TMS data, I'll certainly feel compelled to use this metronomic along with low dose nivolumab. I really appreciate the great study. One thing I'd just like to add here, sir, that the immunotherapy, the normal perception is that is very safe, but the two side effects, especially liver dysfunction and endocrine related issues, are pretty high, especially in elderly people. So one should be watchful for that. I have seen many patients, that's why I can say this. But my choice would be OMCT plus low dose nivolumab.
OMCT plus that. Rajiv?
Sir, I'll be very skeptical about nivolumab now, because that already you've given pembrolizumab
Absolutely.
twice, and you'll have to be extremely gutsy to again think of doing a immunotherapy again for this patient. I'd rather we stick with simple metronomic therapy and take this patient through, and at a later point in time, if push comes to shove, then we can probably consider. Right now, I'm not gutsy enough. I've seen enough and more deaths with patients who have already had some autoimmune side effects.
Okay.
Actually, sir, there's been a lot of study about the dosing of nivolumab. We have discussed in various forum. People have given 1 milligram.
So
per
20 mg or
insulin.
40 mg?
So even 20 mg is fine.
Even 20 mg is fine.
That's also
that is
one can
what
do.
I think, and that was one of the question in the poll which I had put, that should OMCT be a standard first line treatment after given the TMH data? One after another they have presented 2 data into this thing. First it was against cisplatin, and now OMCT versus OMCT plus nivolumab. Both the data have been presented. Should we keep OMCT as a standard first line treatment in patients above 80 years of age? Very quickly, all the panelists, because this can also have a consensus statement.
No, are you asking about locally advanced
in
or
general,
metastatic?
80 years and above, unresectable, locally advanced patients for palliative chemotherapy or palliative treatment, should OMCT be our first standard line? Like Indian consensus category 1 is OMCT.
Sir,
Are we ready for that or no?
Sir, in metastatic setting, maybe we can consider it, but certainly I can't say that it can be the first line, but definitely not in locally advanced, because, sir, we have our own study which was just presented in ASCO. I had patient even up to 80 where we gave concurrent cisplatin with radiation. Patient did well tolerated.
No, those who
So,
are for CTRT definitive treatment, fair enough.
Yeah.
But those who are not for definitive treatment.
So then I would go with very small dose of paclitaxel, and then afterwards probably reserve this for later, because I irritate the tumor, then afterwards allow the immunotherapy to play with it after some time.
Parekh sir, 200 milligram of pembrolizumab, twice challenge and re-challenge, grade 3 toxicity. Both the times patient was lucky, steroids was helpful. Textbook says that now do not challenge patients with IO again. I challenge this patient of IO 40 mg, different compound, different dose. If patient would have died, as you know, Rajiv said, he has seen some deaths, would I have been in soup?
100% yes.
100%. Sir, darao mat aise. Dr. Singhvi, would you have re-challenged this patient with IO? No. Mishra ji? No. Okay. Right. So, how I re-challenge with IO, and again, as Dr. Vanita said, ask patient. So, I asked patient and the family. Again, this patient is independent. She is running her own business at the age of 87. She said, I do not want chemotherapy, whether oral, IV or any form. I do not want surgery. I told her, and I have given a written consent, I said, re-challenging with much lesser dose of another IO, you may land up into problem again, but are you ready? She was ready for that. I had, luckily, there was another patient's son who was a lawyer, so I took his witness also, and gave 40 mg of nivolumab. For 4 doses, she tolerated, there was no side effect of IO. Then I added OMCT, responded very well, and right now she is continuing same with 6 months. I feel that OMCT should be one of the standard first line treatment in very elderly. Dr. Vanita, would you agree on that point? Since you are the one who had presented these data.
Yes, agreed.
Agreed, excellent. Thank you, Vanita. And I realized when I was searching for geriatric oncology for last 3 to 4 lectures, Dr. Parekh, Purvesh Parekh sir has the highest number of publications in India. And I'm very happy. And in fact, this oral metronomic is going on for many years now. And back-to-back 2 data from Tata Hospital really justifies to give that as an oral, this thing, one of the armamentarium.
Sir,
in fact,
my only point, what I'm saying to say is that if like the 87-year-old lady who tolerated paclitaxel carboplatin and CA ovary, here too we will find some amount of response. After you're done with your oral metronomic chemotherapy, and we all know that it's going to give us 3 months or 4 months. If I hit with IV, when the patient's physiology is much better preserved, and then after, if the patient is not doing well, then I go into metronomic, wouldn't it be a better strategy?
So, that Dr. Vijay Patil's talk in Fall B, the time came for our session, but it's a very interesting question, Rajiv, and I am struggling. Should we give standard first line treatment in fit patients, followed by OMCT, followed by again second standard, or should we start with OMCT, followed by first line, second line? These are all the sequence. What I am trying to say is that OMCT has given us those 5 to 6 months where the patient can stay at home, and if they respond, the 20 to 25%, if they respond well, then you have a basically giving them a good quality of life and extending their lifespan. That is how I look at it. Adding nivolumab at 20 mg, which is not cost, which is beneficial to the cost, and 1 year survival from 12% to 40% is a huge, huge number. So I think I am highly impressed by this. The sequencing over the period of time we will learn. So fourth case, we have only 8 minutes left. 80-year-old male, retired army colonel.
So Dr. Atul sir wants to make a comment.
Yes, please. Sir.
Hi Amish.
Sir.
For the third case,
Sir.
so she just got 2 doses of IO, no local treatment.
So their family refused for any chemo RT surgery. She was a localized disease, N1 or N2 ke
So
beech
even
mein.
radiation was refused.
She refused, yes. So pembrolizumab 2 doses, then third dose of pembrolizumab, again transaminitis, this time hyperbilirubinemia also. So pembrolizumab was stopped, sir.
So if I were to treat her basically, then probably instead of the IU or OMT, I would seriously discuss about the radiation, maybe the hypofractionation or palliative dose or this thing. Because what we are trying to achieve is the local treatment.
Right. She went to 3 radiation oncologists and she refused. She said, I don't want radiotherapy. So fourth case, and this is again very interesting. 80-year-old male, retired army colonel, had CA colon right side hemicolectomy done. According to him and according to notes, he was in ICU flat for 6 hours, transferred to general ward and discharged in 3 days. Not a single post-op complication. He used to run and walk half marathon for last 4 to 5 years. Histopath report after surgery was P-T3N2 disease. He was counseled regarding K-pox, Folfox, trials, this, that. He had taken another opinion some other place also. So we decided for Folfox. Put a PICC line. I didn't even do CGA in this patient, because this was an 80-year-old fit patient, tolerated surgery extremely well, walks 5 to 7 kilometers every day, 0 comorbidities. All the parameters were normal, 2D echo normal, PFT normal. Vanita, would you have done CGA in this patient?
Yes.
And what surprises would we have got?
I don't know. I think that's the beauty of the CGA. You can't eyeball the patient.
Okay.
At least that's what ASCO tells us.
I explained to him about CGA, but I told him, I said, you are too fit to do CGA and I'm not going to insult you. So we did that. After third cycle of Folfox, I started with 4, went up to 6. After third cycle, he had grade 3 loose motions requiring dose interruption and dose reduction. 2 episodes of bradycardia was there. I have seen lot of bradycardias on 5FU. I don't know everybody else's experience. Then finally Dr. Ashok Vaid gave me the solution. He said that use less and less dose of antiemetics and your problem will go away. Although problems have reduced by 50%, but it has not gone away completely. And this is Rajiv Gandhi's experience also. They were facing lot of 5FU related cardiac toxicities, and they changed their anti-emetic protocol and things sorted out, not completely disappeared.
So what did you use, sir? What change did you make?
So
very interesting.
basically, they said that fosaprepitant and very high dose of amicept should not be used. I stopped using aprepitant and fosaprepitant in Folfox and Folfiri. Touchwood, it's almost 8 months now. I had 2 patients had temporary bradycardia, stopped and again recovered, but nothing else. We will talk about that later, just this thing. So this patient had 2 episodes of bradycardia, grade 3 loose motions. Being a completely fit person and running marathons, he lost his will to continue Folfox. And there's a time when S1 was available in India. So I said, let's give S1 plus oxaliplatin. Patient completed the treatment of S1 plus oxaliplatin without any problem. So we have CAPOX, and we have this phase 3 study which shows that there is an equal efficacy in terms of PFS and OS. And this is a trial which is going on, and this trial, which is the initial results, S1 plus irinotecan plus BEV is as good as FOLFOX6 plus BEV. This is the study which I am desperately waiting for, Nordic 9. So my question is to the panelists, should we replace 5FU with S1 in elderly patients with GI malignancies? Dr. Kalyan?
Actually, we have no, my personal experience, I have not used this.
There is data from Europe and Japan. Every possible scenario where 5FU is used, they have done the randomized trial with S1.
In
they
Japan,
have found
there's
equally
a lot
efficacious.
of days they are using S1.
Yeah,
and
there is no US data. So if we want to love US FDA, then yes, we are not ready. Manish?
Sir, I have not used S1 in any patient, but one thing I am certain, we should not use capecitabine-based regime in elderly patient, because 5FU is much better tolerated than capecitabine. But yes, S1, if is available, I can definitely consider it.
Okay. Rajiv?
Sir, I have used S1 in the recent past, and I found it to be pretty useful. But again over here, I would have stuck to CAPOX, give a very small dose. Probably like 101.
So Vanita presented the data, randomized data. 60% of CAPOX is as good as 100%.
Fantastic. That's maximum for these patients. 202 is my maximum dose. I don't even check. We check the BSA, but 202 beyond that particular we don't even go, or 201. So stick to that. Patient has less toxicity, good response.
This is this is very interesting. India, I don't know somehow why are we fixated on capecitabine 2-2. 95% of prescriptions capecitabine 2 morning to evening. You are laughing. Please comment on that.
I think, Amish, this is a well-debated topic time and again, and right from when Dr. Ramesh Nivagada started saying 2-2, we have been doing it and it shows response.
We don't, see, we don't know. Problem is that
we don't know, and we are not
2-2 and 2-3, 2-2 and 3-3, there are so many patients who deserve 3-3. But somewhere 2-2 has been fixated in our mind.
Just want to make a point.
See, the same thing, when you give Cisplat, we discussed that just an hour ago. Who all are giving by body surface area? No one. 150 you stop. So similarly, I think here also, 2-2 is where we stop.
So this is exactly one of the reasons I said in India, as most of us or many of us underdose our patient because of many reasons. And on top of that, even capecitabine, most of us, as you rightly said, use 2-1. So all the more underdosing. That's why I said 5FU is a better option compared to capecitabine.
So the S1, yes.
Sir, S1
you
is,
would replace.
I would replace if a patient has persistent loose motions, then I've shifted over. Otherwise, I keep S1 as a shot in the arm. Probably later point in time, when the patient progresses, I'll hit him with S1.
Okay. Chirag bhai, do you think we are ready to replace 5FU with S1? Dr. Ranade is saying yes, we are.
So personal experience only in one patient, but we have the data, and I will be willing to replace S1.
Would be willing to replace S1. Yeah. Last 3 patients and elderly, I have replaced 5FU with S1. They are doing very well. They just don't require to come in the OPD in between the 2 chemotherapy cycles, and they are very happy. We have 1 minute left. 10 seconds comment from Dr. Vanita and from Dr. Prem.
Sorry, comment on what, yeah, Amish?
Concluding remarks, whatever you...
No, nothing more to add. Yeah. Okay. It was a beautiful discussion. Thanks, thanks, Amish.
Dr. Prem.
Yeah, in this particular patient, actually, I would have done a CGA pre-surgical itself. That would have made your life easier.
Fine. I think, these are the 4 cases which I took because I desperately feel that the CGA, what we are doing is not enough. I am not getting the even 50% concordance between CGA, good, bad versus chemotolerance. And I would request that anybody who has a better way of giving me some answers about our geriatric patients, because my OPD is 40 to 50% above 65 years of age. And I desperately need some answers for that. With that, thank you so much, all the panelists, for taking out your time. Thank you so much.
Thank you.